Okay, so this is week 2, part 1, seizures. So when a person or a child has a seizure, there's some kind of malfunction of the brain's electrical system. And what happens is that there is an excessive and disorderly neuronal discharges that are initiated by what they call an epileptogenic focus, or there's a group of hyperexcitable cells in the brain. And the signs and symptoms will depend on the area of the brain that's affected. So the effects may include involuntary muscle activity, there will be a change in level of consciousness, or there will be altered behavioral sensory signs. So it's really important that when a child does have a seizure, that an accurate diagnosis is established, because you want to be able to provide the family with the prognosis, and you want to provide the child with appropriate treatment. All right, so again, it's really important that when a child does have a seizure, you want to distinguish between epilepsy. Do they have epilepsy, or are they having a non-epileptic seizure? So if a child is diagnosed with epilepsy, that means that it's a chronic disorder and they've had 2 or more unprovoked seizures, and it can be caused by different pathological processes in the brain. So seizures are a symptom, and they indicate that there's a problem in the brain. So there's some kind of underlying disease process. So if a child has one seizure, it does not mean they have epilepsy, and they will not be treated on long-term anti-epileptic drugs. So a seizure may be the result of some kind of acute medical or neurological illness. So you want to differentiate when a child does present with having seizures. You want to differentiate. You want to do a differential diagnosis. So you want to differentiate from other brief alterations in consciousness or behavior. So you want to rule out other conditions that might mimic seizures. So are they holding their breath? Are they fainting? And the parent is thinking that they're having a seizure. Are they having tics or tremors? Because oftentimes tremors might look like a child is having a seizure. Or are they having a febrile seizure? So usually if a child's temperature gets up to 38.8 or greater, they can have a seizure. So if a child is admitted into the emergency department, they're having febrile seizures that are related to high temperature, then they're not having, they don't have epilepsy, they're just having a febrile seizure. Febrile seizures usually occur after 6 months and before 5 years of age. So there's usually risk factor. So usually there's a family history. The seizure may always will occur when the temperature is rising and it's reached 38.8 or above. And usually the treatment for febrile seizures, you want to control those seizures, so you would give them some diazepam, possibly rectal diazepam if they don't have an IV, and you want to control their temperature, so you would give them some Tylenol or Motrin, and also the doctor might decide, oh well, let's give them some cold normal saline, infuse some cold normal saline, and that'll help reduce their temperature, in addition to giving them the Tylenol. So all right, so we have classifications of seizures. There's many different kinds of seizures, but we're only going to talk about a few of those, okay? So we're going to start off by talking about partial seizures. With partial seizures, there's no loss of consciousness, and usually when a child has a partial seizure, it involves a small area of the brain. So usually these types of seizures will arise from the cerebral cortex. So they might arise from the frontal, the temporal, or the parietal lobes. They're usually characterized by localized motor symptoms or sensory, or somatosensory, or behavioral or autonomic symptoms, or a combination of these. And usually on the EEG, the electrical discharges will be unilateral. So there's three types of partial seizures. There's simple partial, there's complex partial, and then there's simple or complex seizures that are secondarily generalized. They turn into generalized seizures. We're only going to talk about simple partial and complex partial seizures. Okay? So there's simple partial seizures with motor signs, and that's where the electrical discharges come from the primary motor cortex and the temporal lobe. Those electrical discharges come from the brain that controls muscle movement. They are the most frequent type of simple partial seizures, and the motor movement tends to be clonic. There's clonus, rhythmic, alternating contraction and relaxation of the muscles. And then there's simple partial with sensory symptoms. So those symptoms may include feelings of numbness, tingling. They might complain of pins and needles. Then there's auditory symptoms that include humming, buzzing, or hissing, or visual symptoms where they would see flashing lights or colors. It's important to remember that these simple partial seizures are often thought to be auras, and they're often, some people would consider them to be auras. Then there's simple partial seizures with autonomic symptoms, so maybe they would be, they'd have epigastric symptoms, they'd have some pallor, flushing, sweating, or their pupils are dilated. Then there's simple partial seizures with psychic symptoms, so they would make some vocal noises, or they'd have a sensation that an experience has occurred before, so they'd have a déjà vu. Or they would have feelings of fear, anger, irritability, or they have feeling of displeasure. They're not happy. Then there's complex partial seizures where there is an impairment of consciousness. So the child, when they're experiencing a complex partial seizure, they may look dazed. They have a vacant and frightened look, and they don't respond to your verbal words, or they're not able to follow commands because they have there's an impairment of their consciousness. They are the most difficult to diagnose and control. They're the most common type of seizure, and they're most often seen in children between the ages of 3 years and adolescence. Complex partial seizures may begin with a simple partial seizure, or an aura that's usually a sensation or a sensory manifestation. So a common sensation that is experienced then would be they'd have a strange feeling at the bottom of their stomach that arises toward the throat. The feeling may be accompanied by an unpleasant odor or taste, or a visual hallucination. So small children may have an aura, so they may be fearful or anxious. An aura is considered to be part of the seizure event, and it's often associated with the EEG changes that are seen on the EEG. Automatisms then what are they? They're repetitive involuntary activities that do not have a purpose. So a child may have lip smacking, they might be chewing, they might be drooling or swallowing, or just even there's physical automatisms where they might be wandering or repeating words. Other automatisms may include antisocial behaviors such as removing clothes in public or opening doors of a moving car. Now, in the olden days, before they had the child locks on the car, can you imagine, a parent driving and their child opening the door? that'd be kind of scary. So you want to remember that that the child's consciousness is impaired, so their actions are not deliberate. So you need to do some education to the parents to tell, remind them they don't know what they're doing. So the parent, doesn't make sense for them to scold the child because they're not aware. They have their consciousness is impaired. All right, so now we're going to move on and we're going to talk about generalized seizures. That's where there's abnormal electrical discharges are coming from both hemispheres of the brain. So you have tonic-clonic seizures. So there's a loss of consciousness with impairment of motor function. So if they're standing, they're going to fall. If they're standing or seated, you want to ease them to the floor, and they're going to have apnea and cyanosis, and that apnea and cyanosis will last about 10 to 30 seconds. Then you have the clonic phase. That's where there's intense jerking movements as the trunk and limbs are rhythmically contracting and relaxing. They are not able to control their oral secretions. They may be incontinent of urine and feces, and this phase will last approximately 30 to 50 seconds. These children are at risk for generalized. These children are at risk for generalized seizures. The children at risk for generalized seizures, you need to place them on seizure precautions, and you need to have suction and airway at the bedside at all times. So it's not enough just to have it there. You need to check, as the nurse, you need to check to make sure the suction is functioning, and you need to make sure that their O2 and bag and mask are working. You need to test it. So again, they're swallowing during these generalized seizures, tonic-clonic seizures. Their reflex is lost, so they have increased salivation, and their tongue is hypotonic. So they are at risk for aspiration and airway obstruction. So you want to place the child on their side. So why? Well, because if they have increased salivation and their tongue is hypotonic, their tongue, if they're on their back, will obstruct their airway. So you want to place them on their side. So a child with tonic-clonic seizures, you want to place them on seizure precautions. You want to make sure there's suction airway at the bedside, and you never ever want to forcefully restrain a child during a tonic-clonic seizure. So then you have your postictal phase that usually lasts about 30 minutes. They may remain semi-conscious. They may be difficult to arouse. They may remain confused, or they may sleep for hours. They may have impairment of their fine motor movement. They may have a headache, complain of visual or speech difficulties, and they may vomit. So when awake, they'll complain of feeling tired, they'll complain of sore muscles, and they will have no recollection of the event. All right, so now we're going to move on. We're going to talk about absence seizures. These are still considered to be generalized seizures. They appear in childhood between the ages of 5 and 8 years of age, and they often stop spontaneously in adolescence. These absence seizures can occur without any warning. So usually there's a sudden onset with a very brief loss of consciousness, which lasts about 5 to 10 seconds. Oftentimes teachers will confuse these absence seizures as that the child is daydreaming, or they're inattentive because they have a blank, motionless stare. And because there is a slight loss of muscle tone, they may drop an object, and they seldom fall. They may also experience some automatisms. So they may have some lip smacking, twitching of the eyelids or face, or they may be fumbling with their clothes. Okay, so if a child has been on anti-epileptic drugs for 2 years and they haven't been experiencing any seizure activity, and they don't have those risk factors. So some of the risk factors would be they were 12 years old at the onset of the seizures. They've had a history of neonatal seizures. They've had numerous seizures before control was attained, or they have neurological dysfunction. So, for example, they might have if they have some motor or cognitive impairment. These are all risk factors, and they would not be eligible to be weaned off of their anti-epileptics if they have not had seizures in the past 2 years. Now, if they don't have those risk factors, then they can be weaned. The dose is gradually weaned over 2 weeks. You never ever abruptly stop anti-epileptics, so you got to wean them. Usually 25% of the seizures will reoccur 6 months after the drugs have been stopped. And then in that case, then obviously you're going to start them back on. They'll be started back on medications. Okay, so now we're going to talk about management of seizures. So really, the goal of management is that you want to control seizures, you want to reduce the frequency and the severity, and you really want to find the cause, if possible, and you want to assist family and child to live a normal life as possible if they have epilepsy. So there's 4 treatment options for children who have epilepsy. Children who have not responded to several different seizure medications can be started on a ketogenic diet, because some types of seizures do respond to this ketogenic diet. The ketogenic diet is a high-fat, low-carb, adequate protein diet. So usually the body uses carbohydrates such as sugars, breads, and pasta for its fuel. But because a ketogenic diet is very low in carbohydrates, the fats become the primary fuel instead. So they develop a state of ketosis. With this diet, it's deficient in vitamins and minerals, so they'll be on supplementations also. Side effects of the diet are constipation, they'll have weight loss, so they'll be, thin. They could be lethargic, they could have kidney stones, or prone to kidney stones. They'll have poor bone mineral density. Another treatment option is nerve stimulation. And that's where they'll place an implantable device under the skin, which is the size of a pacemaker. It's under the skin, and there's a handheld device that when the child experiences seizures, that you'll put that handheld device over that implantable device, and it reduces seizures. So usually a child will be considered for nerve stimulation when drugs have not been effective, and it's indicated as an adjunctive therapy for children 12 years old and older who have partial onset seizures. Surgery then is another option, and that's where if the child has a tumor or they have a lesion, so they'll remove the tumor or the lesion, or they'll remove the portion of the brain that's causing the seizures. So surgery is indicated for children who usually have debilitating and uncontrollable seizures if they don't have a tumor or a lesion. So they'll do a focal resection, so they'll resect. They'll have resection of the epileptic focus, the area of the hyperexcitable cells, so excise that area. Hemispherectomy will be done. They'll remove all or most of the hemispheres, and that's usually indicated for children with severe hemispherectic epilepsy. All right, so your role as the nurse is that your role is not to diagnose. That's what the doctor does. Your role is you want to monitor the seizure activity and you want to accurately document the event. So you want to describe that activity in your documentation, and you want to record and note any changes in behavior before the seizure. So you want to describe it, and you want to document how long it lasted and if they had an aura before. You also want to maintain, your primary goal is maintain a patent airway. So you want to give O2 as needed. You want to monitor SATs, their color, their vitals, and keep their head elevated. Or if they're drooling, you can position them on their side. So your main thing is when a child is having a seizure is you want to ensure their safety. So you want to place them on seizure precautions. So you want to side rail should be up at all times. The side rail should be padded. The bed should be in the lowest position. You want to make sure the suction is functioning and it's at the bedside. You want to make sure they have an oral airway is available, and you want to make sure the O2 bag and mask is available and functioning. If the child is standing or seated, you want to ease that child to the floor, and you want to place a pillow or a blanket under their head, and you want to loosen any restrictive clothing. And if they vomit, you want to turn their head to the side, and wipe the vomit, of course, and you want to remove any eyeglasses because that could serve to injure them. All right, so you want to, in the hospital, if they're having a seizure, the first line medication for status epilepticus is that you want to give them IV diazepam or lorazepam. Lorazepam is preferred med because it's got a rapid onset of 2 to 3 minutes, and it has a long half-life. It stays in the body or in the body system for 12 to 24 hours. You want to monitor vitals, especially you want to monitor for respiratory depression. So when benzodiazepams are not effective, which are diazepam and lorazepam are benzodiazepams. Okay? So when benzodiazepams are not effective, the next line of medication would be phenytoin or fosphenytoin. And then phenobarbital is the next line of treatment. So a combination of these meds, if you give a combination of these meds, it's high risk for apnea, so you really need to monitor for respiratory depression, and you need to make sure the respiratory support is available if needed. So you want to have your O2 bag and mask and oral airway available. And the child, if the seizures are not being controlled, even with your medications, then they need to be transferred to ICU. Before I go on, if you have a child that is status epilepticus and they're walking in the hallway and they fall, you see that they're having a seizure, and you get them to the floor, and they continue to have seizures, then you want to call a MedStat. You don't want to worry about, I got to get them back to bed. No, you get them to the floor, and you make sure you put a pillow under their head, and you make sure that they're safe, and that's if their seizures are not being controlled and they're lasting a long time. Then you want to call a MedStat. All right. If it's just a child who's having a seizure, you give them the lorazepam and it helps and it works, then you don't need to call a MedStat. But if you give them their medications and they continue to have seizures, then the MedStat is, you call a MedStat. All right. So now, you want to monitor when a child is on anti-epileptic drugs. You want to monitor the therapeutic and the non-therapeutic effects. So, they come in, let's say, because all of a sudden their current medication regimen that they're on, they're having lots of breakthroughs, and they're having non-therapeutic effects. They're having more seizures. So when they come into the hospital, you're monitoring. The doctor's going to change their medication regimen, and you're going to monitor those the therapeutic effects. Is it working? Are they having less seizures? How long are those seizures lasting? Okay, so when they're at home, for any seizure activity, the family can administer diazepam either under their tongue, buccal, or intranasally, or they can receive rectal diazepam at home. Okay, so that is the end of part 1, our seizure lecture. Hey Cheryl, I'm finished and I don't know how to turn this off. This is Renee at 513. Thanks, bye. It's not turning off. I don't know what's going on. I still see that little line moving, and I don't know how to get to it to turn it off.
Did you click on that little icon on the bottom?
It's not showing up. I just see the icon over here, and it doesn't show any. It just shows that nothing was recorded,
Oh.
and I know it was recorded.
Hit the